In the interest of time, we're going to go ahead and open up this gathering to questions from the audience. And we want folks to come to the microphones. Looks like there's a... Yes, ma'am.
Just a short question, because I'm from Baltimore, so I'm very interested in lead. On your $50 billion for lead, does that include all downstream costs, like, for example, results in violence in prison, or is it just immediate treatment for lead poisoning?
That slide was actually looking at overall costs in the country when it comes to these specific toxins that you'll find in substandard housing. It's not Kaiser Permanente members' data.
Oh, no, I'm saying, does it include all downstream costs from lead poisoning, like the fact that they often end up in prison due to violence?
Those are healthcare costs.
Just healthcare costs.
Just healthcare
Thanks.
costs.
I mean, it's important. Right?
Thank you. Yes, ma'am.
Good morning. I'm Mikkel Moore from Intermountain Healthcare. I appreciate the comments. And for any of you really interested in your perspective on healthcare is a little bit, I guess, late to this in the sense, and yet you are all the leaders leading out in this. How can healthcare, as we enter, also act as a convener of other businesses, chambers, others to get on board with this type of thinking about using our balance sheets, our assets for total health? Have you had any success beyond the healthcare sector, and how can you guide us in our thinking there?
Let me try to make sure that Ross gets in here, because I even forgot to introduce him at the very beginning, and my apologies, Ross. Did you hear that question? Do you want to chime in?
I did. It's loud and clear, and I'll defer to others for the first answer, but I'll jump in as needed.
Okay. Go ahead.
Thank you. I guess what I would say on the convening is because healthcare in so many ways straddles the private sector and the nonprofit sector, and the CEOs of health institutions have a voice and a gravitas that really makes them, I think, unusually powerful in these discussions. Having the weight of that support on advocacy campaigns, whether that's, for example, legislation that would not allow landlords to discriminate based on source of income so that vouchers would be acceptable in more rental properties, or whether it's about creating affordable housing trust funds. There are any number of initiatives like that that are not directly tied to the interests of the hospital or health system, where stepping outside and inviting peers to advocate together, I think, is really important. We're seeing that in a number of the hospitals that we're working with, and we've seen it even in the Twin Cities before this initiative. Very powerful.
Yeah, this is Ross. I think I would agree with all those responses. I would also add that I think where we've seen this sort of engagement of health systems into these spaces where they've historically not been as engaged, one of the risks and opportunities is to make sure that we're not sort of splintering the conversation and assuming that the right locus of partnership is at the level of health systems, because, in our market there's a few of them, and we run the risk, I think, of trying to separately engage the same nonprofit and government partners. And there's just an argument to be made, or at least explored, that the mechanics of connecting the health system, whether it's data or care coordination with these community resources, require that pipelines be built of data and sharing of information. And if we could kind of collaborate instead of compete on this between health systems, we could likely have a model that is easier to engage with and sends more sort of consistent signals at the community level about where the healthcare system wants to engage.
Angela, did you want to chime in as well?
Yes, I would just add that the conversations, being collaborative, you start to flesh out what the priorities are within your different sectors. So as we're looking at health and talking to local government, in our case, they were also looking at how do we invest in communities and what could that look like if the right partners were at the table. And so between working with government and then other nonprofits, we were able to find our common denominator and really help to leverage the investments that each person brought to the table or each organization and the assets that could then be compiled to go deeper into the investments we wanted to make.
Have you had any success, Angela, engaging other businesses in the community in support?
So in terms of where we are, we're the primary healthcare organization involved in our housing investment, but we have been able to engage through our CDFI partnerships other financial institutions who are looking at opportunities for high impact projects. And so in defining high impact, when you have an anchor institution such as healthcare investing in affordable housing, that really becomes a leverage point for other anchor institutions, or other financial institutions who are looking to obtain CRA credit. So they can then align and join forces.
One other concrete example I can share, in addition to my colleagues here have mentioned. So the Bay Area Council is a coalition of 300 plus the largest businesses in the Bay Area, and they just issued a big report around homelessness. Just a couple of weeks ago, actually, and that it helps that our chairman and CEO is actually the chairman of the board of the Bay Area Council. But those issues are so relevant to businesses and the communities where we exist that we're seeing other businesses step up. I mean, you have Chuck Robbins, the CEO of Cisco. You have Mark Benioff, the CEO at Salesforce. You have, I know through some of the most recent effort that Maurice is leading with the Chan Zuckerberg's initiative in the Bay Area, we're seeing businesses step up, and not just in the matter of a few millions here and there, in the tens and hundreds of millions of dollars commitment to this issue.
Terrific. Thank you. We go here. Identify yourself for us, please.
Sure. John Auerbach, Trust for America's Health. I'm thinking back to Admiral Girard's question about federal policy, and is there, and wonder about your thoughts about, is there something that can be done at the federal level? I don't know if that's Health and Human Services or HUD, but is there policy that would help in terms of scaling some of the local activities that you've been talking about so that they could be replicated widely and throughout the country?
It's a great question. Robin, you want to start us off?
Sure. The first thing I would say is having a more rigorous requirement around community benefit and what counts. A lot of things get thrown into that pot that are maybe not directly community benefit. So I think I would step up enforcement and make the emphasis of that money more around social determinants. The second thing, and maybe it's the first thing, is to allow Medicaid funding to go for housing in more direct ways so that it's not a function of individual waivers like in North Carolina, but is more broadly applicable and more broadly understood as being a legitimate and important use of those funds.
Sean, go ahead, Sean. Okay.
What we're seeing nationwide is that the healthcare systems that are investing in this space, many of them are mission driven. And so that becomes a motivator for many of our healthcare institutions. I do think that in addition to community benefit, allowing incentives for other healthcare systems to join in this space, identifying what those potential incentives can be to broaden the range of healthcare organizations in this space matters. For those of us who are accountable care organizations, we are at risk for our patient population from birth until they mature into adulthood. So we have, we have a motivation to keeping them healthy throughout the long term.
I would.
Go ahead, Ross.
Did I jump in? Sorry, this is Ross. I would add two things. One is kind of, again, back to the technical issues of data. I think that we often break down when it comes to the legal and data privacy questions of sharing data across sectors and sharing data having to do with treatment for substance use disorder with the rest of the world. So I think greater standards on that, as well as opening a conversation about data standards in the social determinant space. I think we have a pretty steep cliff between the national standards to define conditions and procedures in healthcare, and a lot of other things that healthcare wants to incent and create and do, where we define and measure those things differently everywhere. So that's sort of bucket one. The second one, it really has to do with how the federal government reimburses risk-bearing entities like health plans for Medicare and Medicaid, and I think that there's potentially a lot of good that could come of incorporating information about social need into how we apportion risk-based payment in healthcare. So if we didn't spend $1 more but recognize social complexity as a predictor of healthcare costs, I think it could open up a lot more opportunities for healthcare organizations to be resourced to kick off and make this work possible.
And I think from my perspective, John, I think of 5 kind of concrete things that the federal government could do. One, we want to make sure that affordable housing is an integral part of any infrastructure potential plan. 2, we want to make sure that we're maximizing funding for existing programs that we know work, like the Section 8 housing voucher, the home program, CDBG funding, HUD Veterans Assistance Supportive Housing. 3, I think we should be thinking about replicating, programs like the HUD Veterans Affairs Supportive Housing and tie it into some of the HHS programs that already exist to support people, whether with substance abuse issues or mental health issues. I think that's a concrete example. 4, I really think there is an opportunity for us to create new competitive HUD funding that's kind of modeled after the Department of Transportation Tiger grants that really push for innovation and out-of-the-box thinking and make it be focused on affordable housing. And then 5, I think there is a role for us to create a housing stabilization fund with the goal of having that fund to be there to provide a one-time short-term emergency housing assistance for people so they don't end up on the street. Because a lot of time, if you prevent that very first time that where your housing is so unstable and maybe you just need a couple $100, $300 or $1,000 to prevent you from being on the street. And if we have the flexibility of having that type of fund, I think that would support a lot of people from ending up on the street. So those are kind of 5 concrete things that the federal government could do.
Terrific. Great question. And don't forget, state governments can play a big role here as well. Yes, ma'am.
Hi, I'm Catherine Berlander. I work at CMMI. I'm the lead for the Accountable Health Communities model. Happy to be here. I'm thinking about our awardees and looking at your successes and wondering, if you could boil it down to one place to start or one key learning or one way that you've overcome a barrier to pass on, what would you say? I feel like I've written down a lot just listening to your answers to other questions, so we can move on to another question if you want to do that. But that was why I came up here. Thanks.
Thank you. Who wants to jump in? No, I'm good. I'm resisting. It's killing me. I will tell you, it's killing me. But
So this is a space where the perfect is the enemy of the good. And I think what we're learning from the systems that we're working with is that if you get started in a way that authentically values community voice and you reach out to partners in an effort to do things together rather than alone, you'll hear what the right answer is. And the right answer is different from place to place. It's more about an approach and a mindset than it is about any specific technical best practice. And so I think the advice that we're hearing from our folks is, say you want to help and then listen and do what you're told.
Yeah, I would say, this is Ross, I would say a couple of things. One is that I think it's often easiest to gain momentum in these kinds of efforts when we pick the really obvious low-hanging fruit of when there's impactable healthcare costs to be saved in the short term. And I think that can really help build momentum, both political and organizational, to get this work done. But I think pretty quickly there's a fork in the road often about, do we do more of that? Or do we sort of reframe the conversation and say, now that we have these resources, ideally sort of back into our community, how do we reinvest them for sort of the greatest community health impact? And that requires really different work and really different structures, I would argue. But I think we're going to need to be ready in this work to recognize that there's a limit to the economic self-interest of the healthcare industry in this work, and it's not probably enough to fix root cause. And so I think calling that out and anticipating that is really important.
Anybody else want to chime in? No? Okay, terrific. We'll go over here.
Hi, Stacy Lindau, University of Chicago again. Since we're focusing on housing, I'll try to frame my question that way. I wonder if you imagine a world where we largely move from the business of sick to the business of health, or we largely move from fee-for-service to value-based payment. To what degree do you think other healthcare institutions, beyond ones that are already risk-based or largely value-based, will shift to adopt or implement your strategies? To what degree are your strategies replicable in that value-based world? And what do you see as the barriers or the reasons why we wouldn't move in that direction?
Yep, Robin.
So I think it's really important when we're thinking about social determinants of health to think in terms of how do we invest in people. This came up earlier today, investments in human capital generally, because the problem is not so much that we don't know what to do, it's that we're not doing what we know. And I think there's an investment in narrative change. And Tiffany Manuel, who has done some really interesting research in this direction, calls it the we and the why. There's something about framing the importance of this work in terms of the future that we as a society want to have. And I think there's nothing clearer to us without additional research that for the society to prosper, we have to have healthy people. And we know what to do to have healthy people, so now we have to do it. So the shift is actually not at the level of healthcare institutions as much as it's the level of the social narrative and the kind of dominant framing of this issue to be something that we as citizens care about, at which point the health institutions, I think, are going to take care of themselves.
I'm happy to. I live in the world where we are a health organization that is focusing on health, but we're there for our members when they get sick. But the reality is, as an integrated health system, we have been value-based since Kaiser Permanente was born. And I think for me, that puts that work that we do at the core of our business strategy, as opposed to this nice thing that we do on the side. And I think, if you're thinking about if we think about our 12.4 million members and how do we optimize their health, we know we have to focus on their mind, we know we have to focus on their body, but we equally as much know that we have to focus on their communities, and that becomes an integral part of how we do business. And it reflects even on how we're structured as an organization, all the way from the board level, where you have a committee that focuses on clinical quality and a committee that focuses on community health. Even on our executive team, the same way we have a chief medical officer, we have a chief community health officer. I mean, it just kind of brings that different mind of thinking, the different way of thinking that really integrate this work to be an integral part of the way you run your business.
I would also say just identifying who is the population that you want to serve. So many of us who are investing, for example, in affordable housing, we're looking at various populations. It could be our patient population, those who are the homeless population within our organizations and the population that we serve, or it could be even the broader community. And so looking at what ultimately you want the social impact to be helps to identify who you need to convene and bring to the table for broader discussion. Then I would also add that top-down approach really does make a big difference. So having the support at the highest level within the institution, sometimes we're making the case and sometimes that support is already there, and so they're leading from top down. And so the leadership level and making sure that they're on board is a huge factor in success. Last question, and then we're going to wrap up.
Hi, I'm Joanne Lynn. I'm the director of the Program to Improve Elder Care at Altarum. This has been great fun already. I mean, it's so resonating with kind of the fringe that I've been occupying. So it's fun to hear you and your optimism. But nevertheless, I'm going to ask you to look a little into the future. And on Wednesday, just a couple of blocks from here, Health Affairs brought out a paper showing that by 2029, the population between 20% of income, which is about where Medicaid kicks in, and 80% of income for people 75 and up, will have half of that population unable to afford housing in their community. And that population in 2029 is not yet our largest elder care population. Our largest elder care population is another decade into the future. So this is a new population of people who face homelessness, and almost all of them will be ill. Almost all of us will be ill by that point, or will be ill during the time from 75 forward. So we will be in the healthcare system and homeless in old age in very large numbers. The answer in the past has been to have people spend down to Medicaid and be in nursing homes. That's neither desirable nor affordable for large numbers. So I wanted to have you reflect some on how these efforts apply to people who, yes, there's still a lot of prevention to do, but they are living with disabilities and illnesses and without the resources to purchase housing.
I can start, and I have to tell you, I read the health affairs piece, and I'm very bothered by it, to a point that I've actually flagged it to every member of our national executive team, every one of our regional presidents, every one of our executive medical directors. And the reality is, while it's really important that we invest in the conditions for health in our communities, we still have people that we need to make sure that we're able to address their social needs. And, at some point, I'd love to be able to get to a point to talk about our approach to thinking about not just how do we screen for needs, but most importantly is how do we get to a point where we can predict who are the people who are going to need the interventions and when and what type of interventions so that we can prevent it from happening. And what we've seen, within our own system, while we do a really good job when we screen members and identify their social needs and connect them to community-based organizations, where we're seeing that we're even more successful is when we're predicting those members who actually would benefit from a certain intervention, whether it's housing insecurity intervention or food insecurity interventions, and getting to that point that, to John's point early, we have to do both. We have to be able to focus on individual people and their social needs and be able to connect them to services, and we have to be able to think about the conditions for health and equity in our community so we can create the right conditions so those needs are not bubbling up down the line. But we absolutely have to do both.
I am getting the sign here, and I want to stay out of trouble, so I want to thank the panelists. Please do that with me. Including Ross. And you have a break now. We will start again promptly at 11:15. So thank you all.